मोबाइल म्यूट कर लेना प्लीज, बीच में नहीं कर सकते। बिकॉज वी आर गोइंग लाइव आल्सो, सेशन विल बी लाइव, तो मोबाइल की ट्यून बीच में बजेगी, अच्छी नहीं लगेगी, ठीक है? तो म्यूट कर दो।
Okay. My city.
One copy.
I request all the staff to have our guest celebrate and give her honor.
Indian tradition to try a turban on guest's head.
I like.
Better visible, yeah.
सर पकड़ी बाकी आती है आपको?
Hello everyone. How are you today? I think you got the idea who is among us today. Once again, I would like to tell you that we have Miss Emily with us today. Uh,
चलो ठीक है।
This will be a first. This will be a first. So tell me about the tradition.
No, ma'am, you have to say we'll tie turban.
What is the tradition?
Tradition is this, that this is the honor, a symbol of honor.
Thank you. Please have a seat, ma'am. Well, I'm falling short of work, but I will try to rise the best of my abilities to tell you about a legend, Mr. Kelly, who has 42 years of experience in the field of physiotherapy. She is the voice and president at International Organization of Physical Therapy in Mental Health. She is an accredited mental health first aider and also represents also the national chair representing Queensland, the mental health group of National Advisory Council of Australian Physiotherapy Association, which is also known as APH. About the educational background of the LLA camp, he graduated with Bachelor of Physiotherapy from Queensland University and Master in Cognitive Behavioral Therapy from the Flinders University, Adelaide. Apart from her clinical services, she has undertaken rural service in Broken Hill and has an interest in facilitating better rural health outcomes. Now, I will not take much time and would like to invite Ms. Ellen on stage to throw some light on psychotherapeutic approaches in physiotherapy with her wonderful experience. Thank you all.
Welcome, everyone. Thank you for making me feel so welcome. I feel so very special to be here. I was saying to Dr. Jane, I feel like all the gods have spoken to each other to land me in this place. I mentioned to this wonderful man here, Himanshu, that I was struggling for personal reasons to be here. And we started to chat about catching up, and here I am. We cannot plan that. It happens in the wind. I want to start today, apart from thanking you all, is to say happy birthday to my son, because it's his birthday back in Australia. Thank you. I am not sure exactly as to the level of mental health physiotherapy in India. I think it's a very new area for you, is that correct? Yes? I have been involved in the Australian Physiotherapy Association Mental Health Committee since we started forming a group in 2015. I have been the Queensland Chair, Queensland State of Australia, been Queensland Chair for about 7 years, and the National Chair for 2 or 3 years. Mental health physiotherapy is a fascinating career pathway and one that I consider to be inevitable. There is a saying, perhaps you've heard, that without mental health, there can be no true physical health. Has anyone heard that saying? Just show me your hand. Have you heard that saying before? Do you know that saying was made by Dr. Gibson, the first Director General of the World Health Organization, 50 years ago? 50 years ago, it became evident that there was this relationship between physical health and mental health, that there is a bi-directional relationship between physical health and mental health. And physiotherapy is now moving towards integrating mental health into what we do. I'm going to read you a little bit about our mission statement in Australia, is that okay? In terms of mental health physiotherapy. The overarching goal of physiotherapy is to improve health, and physiotherapists know firsthand the reciprocal relationship between physical and mental health. We in Australia and on the International Committee, of which I am Vice President, support the World Physiotherapy definition of health as defined in the World Health Organization Constitution of 1948 as a state of complete physical, social and mental well-being, and not merely the absence of disease or infirmity. There is no health without mental health. Physiotherapists work with their patients to reduce their physical suffering, which reduces psychological suffering. And through their diagnosis, treatment, and patient management, they also reduce psychological suffering, which reduces physical suffering. There is this reciprocal relationship. There is therefore an urgent need to acknowledge and formalise the role of physiotherapy in mental health care. So we encourage physiotherapists all over the world to formalise the role of physiotherapy in mental health care. What is it that we can do as physiotherapists in mental health? Does anyone have any thoughts on that? What can we do?
मेंटल हेल्थ में क्या कर सकते हैं हम? किसी की कुछ आइडिया है? क्या रोल होना चाहिए?
आप हिंदी में बोल सकते हैं, वी विल ट्रांसलेट, डोंट वरी, डोंट हेजिटेट, यू जस्ट स्पीक आउट, आपको जो भी लगता है.
One thing that we do as physiotherapists in mental health is work with the biopsychosocial model of care. Is that something you're familiar with?
Yes. Yeah. I think you heard about biopsychosocial model.
Biopsychosocial model of care. So in terms of health, we know that biological factors impact physical and mental health. We know that psychological factors impact physical and mental health. And we know that social and spiritual factors impact physical and mental health. So in working in that patient space, we understand that chronic condition that we need to work with biopsychosocial and therefore integrate different aspects of care so as to achieve optimal outcomes for the patient. Who has ever worked with someone and given them a perfect exercise program and then found that they lacked the motivation to carry out that program? Who has ever found that a client breaking down his physiological system? Have you known what to do in that situation?
I'm a gynae therapist, and I have found many patients with lack of motivation. They have lack of motivation. They are not willing to do exercise. They come with the energy to do exercise, and during exercise, they get lack of energy to do exercise. That time, we have a role of analysis of the patient. We do psychoanalysis of the patient. What is of for them they are not exercising, they are not exercising. We find out the reason. They come with me to meet. We are then energetic to do exercise, and then they did not get any motivation to do.
Yes. And what do you do when that happens?
We counsel, and every hospital we have a psychologist. They counsel the patient, and they throw the light to right side of the light. They throw the light, and they give motivation and well-being and right direction. What is the role of exercise and what is the role of healthy well-being? They tell.
Yes, one of the most important things that we do as physiotherapists, and I'll talk now about the policy statement of the International Organization, is one of the first things is promoting exercise and movement. And Other aspects of there include sensory awareness, sensory and motor awareness, education around pain and around psychological conditions, education around stress management, and also maybe developing and touch in terms of helping somebody feel safe in experiencing human and therapeutic touch. The other aspect of physiotherapy and mental health that's is evolving much more rapidly is physiotherapists being involved in screening for mental health conditions. And that is something that's evolving more and more. As a physiotherapist, when somebody comes to see us, we can ask about lifestyle. We can ask about sleep, munching notes. We can ask about, we know that sleep disorders impact on pain perception. We know that sleep disorders impact on memory and ability to concentrate and ability to carry out self-care. So working with sleep disorders is a very important part of being a mental health physiotherapist. Another aspect of being a mental health physiotherapist is working with eating disorders. Does anybody here work with eating disorders? No?
Eating.
Eating. And apart from eating disorders, there is disordered eating. So disordered eating is something that we can ask about again in our assessment when talking to patients when we're doing our initial assessments. How can a patient sustain the energy to carry out their program if they're not eating well? So it is important to check in on the patient's eating patterns and frequency, type of diet, etc. We also know that there are certain diets that facilitate mood, such as the Mediterranean diet, with olive oil and fish and green leafy vegetables. I'm sure that there is very excellent Indian diets as well. But these are the things that we can discuss with our clients within our scope. It is within our scope to ask these questions about lifestyle. What it is you eat, how well you sleep, how much exercise that you do in a day or a week, and encourage the recommendations by the World Health Organization of 300 minutes of moderate exercise a week. Really know what it is that you don't know that you want to know about in terms of what I'm talking about here. Are you of exercise can be as good as antidepressants for some people, mild to moderate depression. So imagine that rather than taking your tablet, we can encourage someone to do a 20-minute cycle or a 20-minute fast walk. And that is useful as a mood doing stuff. Who has ever done that themselves? Being stressed out, being said, I just need to go for a run and get my head together. These are the things we can do with our patients as well. In terms of anxiety, the exercise that is recommended for anxiety is the high intensity amount of anxiety, the high intensity interval training. So doing short bursts of interval training can assist with anxiety in terms of working with the stress cycle, the fight and flight response cycle. So that in fight and flight, when somebody is anxious, they are caught in that cycle of being activated in the stress response. So by doing the high intensity exercise, that person is dispelling that process and allowing it to switch back off. Those things are very useful.
Ma'am, I have a question. How to motivate that person to do exercises? Like high intensity exercise work as a medication for a depression patient. But how to motivate that patient, because he is already into depression. He or she, a patient is in depression. So how to motivate them?
Okay, very good question. I think this is the crux of what mental health physiotherapy is. You know, that there are many people that we work with who go away and do exactly what we tell them to do. And they come back and we go, gee, I'm a good physiotherapist. You know, that worked. The challenge is when it's not working, when somebody is very low in motivation. One of the things we can do is something called behavioural activation. Have you heard of behavioural activation? It's a cognitive behaviour therapy technique. So when behavioural activation is a way of, as the term implies, activating someone to behave a certain way by providing a structured program. So somebody would come to me and I would give them a diary for the week. And they would write down all their physical activity that they do in a week. And they would come back and we would look at that together. And then we would determine what we need to adjust to achieve the goals and outcomes that this person wants to achieve. Does that make sense? And you can schedule it in the same way that you work with chronic pain management. So somebody who comes in with chronic pain, I'm sure you do the same thing, that may be able to walk for 10 minutes and then so then you may schedule in for the next week. Every day they work at 80% of that, and then you increase it. The same thing with low mood. You look at what the person is doing, and you look at the goal that they want to achieve, and you schedule in improve mood. It's not about getting fitter. It's not about exercise. It is about facilitating the psychotherapeutic benefits of exercise to improve mood. Once the mood improves, then the person is able and be able to consider possibilities for more options of improving their physical activity. The thing you need to schedule in is something pleasant they like to do. Whether that be paint a picture, whether that them. Things that work within Australia and internationally are things like the different yogas, yoga nidra, yoga, and mindfulness, mindful-based movement and activity. It may be more mainstream for the physiotherapists, I'm not sure. In Australia, I train specifically in mindfulness and in yoga nidra to work with that within our therapy sessions. The thing that I wanted to talk to you a little bit more about today as well is trauma-informed care. Is that something that you work with, trauma-informed care? In terms of mental health physiotherapy, there are, I think, I talk about it in two different ways. There is mental health informed physiotherapy and there is mental health focused physiotherapy. So you can work with mental health informed physiotherapy, which means that I take into account mental health aspects of care when I work with anyone. And I choose to understand how this person is feeling and how that impacts on what we're doing in our therapy. Mental health focused physiotherapy is more about focusing on targets, like as a target, I'm focusing on improving this person's. As a target, I'm focusing on decreasing this person's level of stress. As a target, I'm focusing on decreasing this person's anxiety. And that will help you determine what intervention that you're wanting to use. Now, it depends on how much the clear pathway is active. In my clinical practice in Australia, I am heard by doctors who will refer clients to me with depression and anxiety. So I have clients that walk in the door who will say to me, my shoulder, I have a sore shoulder and I have a very bad relationship with my father. We come together and I see this as the path where we're going, in specialisation. It may not want to specialise. You may say, thank you for sharing that with me. You may validate that person and help them to feel safe within the trauma-informed care, and you may refer onwards. Or, if you wish to become a mental health physiotherapist, you may direct to training and work with this client. I will tell you a couple of stories like that. When this client was referred to me for a sore shoulder, but when he came in, his presenting words were, I'm having trouble with my relationship with my father. So in terms of trauma-informed care, the way I relate to that is there's a testing of the relationship. He's wanting to know with me, can I share this information with you? Is to bring all of me into this space. Then I asked him, would you like to talk more about that today? And he told me a little, and the story wound around, and then it came back to the shoulder, and then I say to him, what would you like us to focus on today? And he looks up and says, my shoulder. And so then it's physio as usual, and I think that's an important point to make, that within mental health physiotherapy, it is collaborative. It is choice of the person you're working with. Somebody comes in low mood, anxious, we don't go, I need to make you better. I need to fix your mood. I need to fix your anxiety. We don't do that. we ask the person, what is it you would like me to help you with today? They may or may not know specifically. They may, like this man, meander around. When I saw this man the second time, his shoulder was better. One session, he had full movement. His neck was sore. So somaticization is common, isn't it? In depression, anxiety, and trauma. This time, and this is where manual therapy is very, very important, and safe touch, and establishing a relationship with the client. For many clients who've experienced trauma in their life, and I will, with respect to my client, share some of his story. He was a man in his 50s. When he said to me, I have trouble with my shoulder and I have trouble with my father, his father was living in South America. He was in Australia with me. He was 50. He had experienced difficulties with his father as a teenager. His father had been very negatively critical and very physically abusive. So this man, and this we discussed this with him, is, and this is what I believe, that the physical representation is offering an opportunity for healing. It is bringing something to awareness that wants to be resolved. Now sometimes, and I think this is where we have a unique place to play as therapists, physiotherapists, we don't always have to go into the nitty-gritty. We don't have to solve the psychological trauma. We have to provide a safe space for re-establishing connection with another human being. This man was looking to establish connection with another human being and be able to share his story. I saw him twice and his pain was gone. Hi. Thank you. That's not me. I do believe it's timing. There's perfect timing. One of the things we talk about in addiction medicine is that it can take up to 7 times for someone to go through an addiction program before they break the cycle. It can take some of our clients 7 or more times to break their trauma cycle. We all have clients that we see over and over. Do you not? And you think, oh, here they are again. And I'm going through the same thing. And I always say it is up to us. It is not the responsibility of our client. It is up to us to find out, what can I do differently for this person? Where am I not getting through to this person? Where am I not listening to this person? Where am I not hearing what it is that they are wanting to tell me? Because people want to be listened. People want to be heard. I have another lady who comes with pain in her legs, and her husband had passed away, and she was in grief. And she was also feeling guilty because her husband, with respect again, her husband had experienced cancer and was in palliative care and had some brain metastases and was very aggressive and angry. He wanted to go home and die at home, which of course is something we normally would support. But his doctors had said it wasn't safe for him and it wasn't safe for his wife. And so she had to say no to him and support him in staying in the hospital until he passed away. And she got incredible guilt about that experience. And so a lot of our physiotherapy was talking about her guilt, talking about that feeling. When somebody feels guilty, what often do they feel that they need to receive? Punishment. I've done the wrong thing. I need to be punished. I am bad. Is that correct? I feel guilty. I've done something wrong. I am bad. Therefore, I need to feel some pain. And so the body can present with muscle tension. If I feel bad about myself, do I feel happy and light? You know, I feel tense and I slump over. And so with this lady, again, talking, letting her talk, you don't have to. Counselling helps. But if you are not a counselor, just listen. Just listen and support the person they are contributing, that they did well in that situation in terms of a strengths-based response to trauma. There are many stories, and you will have many of those yourself. When it is like opening the floodgate, because I am a counsellor as well and a psychotherapist, I work with CBT therapy, cognitive behaviour therapy. So I also have trainings on that side of the fence. And I will say to you that psychotherapists and counsellors want to be physios. They want to be able to work physiologically with the body. They want to be able to touch, and they can't. As physiotherapists, we can use manual touch. We can incorporate that into what we do, as well as our trauma-informed care physiotherapy. Do you have any questions on that? Would you like to share any stories?
How to motivate a person who every time comes with the excuses that I can't do, learn the exercise, and then afterwards, 2 to 3 days after he come up with a new excuse. He's not in a depression. He doesn't have any kind of reasons, but only one thing, that is excuses. A lot of excuses.
I can't do it.
I want to, but I have a lot of excuses why I can't do this. I have a reason to do that. I want to be healthy, and I have 1,000 excuses that I cannot do the exercises. Every time the patient comes to me and then he have a new excuse that I can't do this. How to deal that kind of patients?
He doesn't have a big enough reason. He needs to find a reason.
Yeah.
You will find, you know about motivational interviewing, I'm sure. There are reasons and needs, and you'll find that people will change behaviour when they need to, if they are sick. If they see their best friend have a heart attack, what do people do? They go, oh, I need to look after myself. Often when people do that, motivated by a need, once they feel better, they go back to old patterns. So it's about developing a big enough reason and being with that person at where they're at in their journey. Even if you can change a thinking pattern one little bit, you will get there. There's lots of questions you could ask that person. Why I would suggest that person is always busy. That being busy is a way of numbing out to their feelings and coping with the world. That we all learn patterns of behaviour from when we're children. So if you were rewarded for being really busy as a child, you will find it hard to find time for yourself. If you were rewarded for looking after other people, you will find it will be hard to find time to justify looking after yourself. These are all ways that we've learned to cope with our emotions as children. In terms of any other questions with that? Yeah.
Since when you're practicing mental health, what makes like that into the same?
Okay.
Why and when is like?
Well, the reason I started mental health physiotherapy was because I stopped being a physiotherapist. I had been a physiotherapist for 20 plus years, and many of my clients came to me and would say to me, I always remember what you said. And I would go, I have no idea what I said. But I realized that the interpersonal relationship and the talking had a lot to do with people getting better. And I felt at that stage that I couldn't be a physiotherapist the way I wanted to be, so I stopped being a physiotherapist. I hope I don't talk any of you out of being a physiotherapist. It is a wonderful profession, and I do say I was brought back to that. I had a couple of years off. I call it my wilderness years. I travelled over to Nepal and India, and I trekked. And I trekked through different mountains. And coming back, I was meditating, and I said, what will I do next? And my message was go back to physiotherapy. And I said no. I felt a big knot in my stomach. 12 months later, I was told again, go back to physiotherapy, and I was no knot. So I went back to physiotherapy, and that's when the APA was formed in the mental health group. So the timing was meant to be. There's probably another answer to that question. I was brought up in a household with domestic violence. So as a child, I would watch my parents. And my father was adopted. He grew up, my father struggled with his being adopted. He found out that he has an Indigenous father. And my father ended up becoming an alcoholic and drinking, and was a loving father in many ways, but there was domestic violence in my home. I remember as a child sitting and looking up at my parents, thinking, why do big people do what they do? And I think that probably put me on my path of trying to understand human behaviour. I don't think I'm any closer to the answer, but the journey is being on the journey. The other part of that question is also, and this is what I urge you to do, is to find a path in physiotherapy that allows you to be all of you in physiotherapy. I could not continue being a physiotherapist without being able to bring my values and my morals and my ethics to work legally. I would rather not be a physiotherapist. So mental health physiotherapy for me allows me to connect completely with the person, have an honest heart conversation with the person, and be guided by them. Now, this is what I will say. This is what is your name? Ankita. Ankita. Did I say that? Ankita? Ankita. Ankita. It is difficult when you step into mental health, you stop being the boss. You stop being the boss. It is very much about taking a back step. And if this person only wants to go there, you go there with them. If this person goes backwards a step, you go there and hold them. until they're ready to go forward. So in mental health physiotherapy, it is about taking the time to understand the person. It is not for everybody. Understanding, though, that a person is more than their body is important for all physiotherapists. And understanding, some of you will have treated people. Has anyone ever treated someone once and they got better and you can't understand why? Yes? Because you created a safe space for healing and their body did the healing. And that is what we're looking to do. The other thing I will say, I just want to be clear though too. I'm talking generally and then I'm trying to be a little bit specific with you. The things that we advocate in terms of interventions for physiotherapy is your movement and exercise, your body and sensory awareness, so your mind-body interventions, your manual therapy and safe touch, so working with people to feel safe again by being touched, your lifestyle education, so talking to people about healthy choices. We know that people with mood disorders don't choose, aren't as good at choosing healthy behaviours. So supporting people in that. Stress management, education around stress management and pain management as well. And also going into discussing goals, beliefs, and held assumptions that hold people back in life.
So we are not able to hear you actually. The question you're asking, we are not able to hear you.
Okay, I can speak up.
Okay.
Am I audible? Okay, let me speak louder. One more question. As usually we refer the word motivational interview, as listening is important for the participants. So, can you give us some practical tips how to apply this motivational interview while creating the session?
So motivational interviewing is about, again, working with a person's reasons and needs. And it is about always allowing the person to make the choice about which direction they move. And this is why I say it is often different to being a physiotherapist in other fields, which is much more directed. So motivational interviewing will be about asking the person what it is that the goal that they want to work towards, and then helping them identify those reasons that would be important to them, and helping them to. Motivation interviewing is about exploring ambivalence. So there's two sides of the coin. I could do that, but I have so much to do. I could do that, but I have so much to do. So you may say, it sounds like you have a lot of things on your plate. It sounds like a very busy person. Now the strange thing is when people like to argue with you. So when you say that, they often say, oh, but I do have a bit of time, and it comes back the other way. So it's, you know the term rolling with resistance. So you go with the person's complaint, excuses, and agree with them. It sounds like you're too busy to focus on your health at this point in time. And they may say, yes, I am, but in 3 months' time I will be better. Great. Let's make an appointment in 3 months' time. Or they may say, actually, no, I do have some time. And you can work with them in that way. One of the things that in cognitive, has everyone heard of cognitive behavior therapy?
Yeah.
Quite common. So the basis of cognitive behavior therapy is it's not what happens to us, it's how we interpret that. And so if you're working with someone with cognitive behavior therapy, and I always say, work with what works, what's the most simplest thing to change? So if somebody is having trouble getting motivated to exercise,
So it's a good disturbance are like therapy. Human आवाज क्लियर करने का disturbance आ रहा है. Sorry for the interruption.
so in cognitive behavior therapy, there may be a trigger, something that triggers somebody. They have some thoughts, some feelings, emotions, behavior, and it's all about a maintenance cycle. Whatever pattern of behavior that person is doing is giving them some relief in some way. So I go to the physiotherapist, they tell me to do some exercise. When they tell me to do some exercise, I think I have so much to do. When I think I have so much to do, my body gets tense. More and more tense, I feel more fatigued. I then think I don't have the energy to do what I have to do, and then I get more and more upset because I'm so busy and I can't focus on myself. And then the easiest way to get relief is to not do anything. And that's called a maintenance cycle. So when you're working with somebody with CBT, you have to look at what's the stuck point. Is it, the stuck point could be the therapist telling you what to do. The stuck point could be the thought, I have so much to do, which then creates anxiety about never get everything done, and the fear of what will happen if I don't get everything done. So it's like picking out the thing that's getting in the way for that person and talking through that. That's very, on one hand it's a simple process to do, but it takes a bit of talking to get through that. But start with the thing that is most easy to change. I always say to the person, what's the easiest thing to change here? Can you change the bit about behaviour going to the gym? They may be able to change that by putting their shoes out early the next morning so there's less stress about getting themselves out the door. Or is it easier to change the thought? For some people that will be, they don't realise that that thought's getting in the way. So for some people you may need to talk about the thought.
Ma'am, I have a question. So we have to ask the patient what changes we can bring into you, or like we have to direct him. These are the changes we want you to change. So from there we start. So do we ask or we do by ourselves? Like how it will be?
It has to be directed by the patient.
Directed by the patient.
Yes. Yes. So you have to allow the patient to choose what it is. This is the change in the thinking. Is that in other forms of physio, you may say, this is what you need to do, right? In mental health, you need to say, what is it you would like help with? And then you can talk about, these are the options. What would you like to try? And then support the person in that way. Sometimes they need lots of options and sometimes they don't.
What if they didn't come with anything? Like they say, first patient is into depression, the client is into depression. So he might say, "Ki, I don't want to change anything in myself." Then from where we have to start? I saw one patient in my clinical life actually. She was into depression and she was on medication from last 6 to 7 years. Someone sent her to me for her back pain, for shoulder pain. Then I said, I think you need help. She said, no, I don't want to change anything in my life. My husband pushed me to go to a physiotherapist, so I'm here. Or whatever you want to do, I'm not interested in doing anything. And she just lie on that eating pad and she said, I'm fine now, I'm going, I'm leaving. For 3 days, she did the same routine, she followed the same routine. When 4 days, I said, it is of no use to come to me if you are not saying anything or if you are not coming up with anything. Then how to motivate that patient? She don't want to change anything in her.
I would say that you can't motivate her, she has to motivate herself. And if that's where she is at, that's where she is at. Some people will take a long time to shift. Something will be happening while she was lying there. You will have been assisting her in some way. But it has to be her choice. You could be having conversations like, it sounds like you are very happy with everything that is going on for you and you're okay with how things are. And she may say, yes, and there is nothing you can do.
Yes, always she is saying, yes, I'm happy, whatever is going on. She take medications and she slept whole day. Her husband is saying, Mom, at least change her behavior a bit. She's not taking care of her kid also.
Well, you could have conversations about finding out again, what is the thing that would motivate her? Is it her children? Is it something? Because her husband has said that's what she has to do, will not be enough. Will not be enough. And in Australia, we would again be guided by the patient. It has to be their choice. If they don't want to do, they don't want to do anything. You can't do anything. No. No. You can provide, this is the thing, if you can provide a safe space, people will come back to you. They may come back in a year, they may come back in 2 years, they may come back in 5 years, but they will come back. And as I said, some people will take 7, 8, 9 times, and the timing will be right. So, yeah, we can't fix everybody. We cannot fix everybody. Everybody has to choose for themselves.
I have a query. You mentioned a case was a shoulder pain and the bad relationship with the father. So, what commonly as a physio, we outcome measures to quantify our progression. So, when you mentioned like we are like suggesting something to the patient that has improved the mood of the patient. So, should outcome measures be directed or to quantify the mood of the patient or to quantify the range of motion, like physical motion?
And the mood of the patient. Do you know the measures PHQ-9 and GAD-7? PHQ-9 and GAD-7, do you know that?
Yes, you mentioned.
So I would encourage all physiotherapists to do screening and do psychological outcome measures. The ones that I recommend you work with are PHQ-9 and GAD-7 and the K10. Some people use the DOSS, the GAS-21. And they're the most common ones, and the geriatric depression scale for older people is very useful too. So all of those measures you can do at the beginning of a session you can do halfway through your treatment programs, and they are useful for tracking progress, and they are useful for determining whether you need to refer on to someone else.
So what comprises the treatment protocol? Psychotherapeutic as well as physiotherapeutic methods or psychotherapeutic? And that
Both, but you have to fit your outcome measures to what your targets are. So obviously you're tracking range of motion if you're working with someone's shoulder. But if you're also looking at improving mood or decreasing anxiety, then you're wanting to be doing the PHP9 and GAD7 as well.
So when the patient will come for the treatment, they will have some conversation as well as they suggest some treatment. Is it a suggestion? Like some maybe so that whatever comes under the area of physiotherapy.
Okay, so I would suggest if your initial assessment that you add in some lifestyle questions. So ask about sleep, ask about their physical activity, which I know you do already. Ask about their eating. You know, how many times a day do they eat? It is surprise. In Australia, the incidence of eating disorders is skyrocketing. And disordered eating is sort of that transitioning towards that. And that is skyrocketing. And that affects behavior. And that affects motivation. So ask about those things. And sometimes it's just a little bit of education around the importance of regular eating, regular sleeping, sleep hygiene, and so on. There are two quick questions you can ask: the PHQ-2 and the GAD-2, which is the first two questions of the PHQ-9 and the GAD-7. So they can be integrated into your physiotherapy assessment very, very simply. You know those? So the first questions in the PHQ-2 is just the first two questions. How often in the last 2 weeks have you felt down, depressed, or hopeless? And in the last 2 weeks, have you lost interest or pleasure in doing things? So they're the first two questions. And you ask those questions, and the answers are not at all, several days, more than half a day, nearly every day. And you rate those 0, 1, 2, 3. And so 2 questions, 3 or higher indicates it may be important to screen more for depression. So you can progress towards a PHQ-9 if you get 3 or more on your PHQ-2. Does that make sense? And they're questions you can slip into your conversation very easily as well. The GAD-2 is how often in the last 2 weeks have you felt nervous, anxious, or irritable? And how often have you had trouble stopping or controlling worry? So when somebody, again, you can rate those questions 3 or more, then that's a high statistical specificity for generalized anxiety. If that comes up, then you know that working beneficially, if the PHQ-9 is 3 or more, PHQ-2 is 3 or more, you know at least that working with activating behaviour is going to be very important. Getting somebody moving to improve their mood is going to be the most important thing. In the GAD-2, if that is high, you may need to start working with relaxation and breathing techniques to relax that person enough so that they can hear the information that we're talking about and that reduce their resting body level of tension. Does that make sense? So I personally use both of those In adults, I use the geriatric depression scale, which is a 15-point scale that is very useful for working with older people. Interestingly enough, with older people, that the evidence is around that there's a correlation between depression and step length. Step length and so the more you work with people and get them striding and faster, correlation with less depression as you get older. And I love that. I love that when we can target something very physical and it has consequential behaviour that impact on mood. For example, your forward head posture. Forward head posture is associated with increase in sedentary behaviour. Increase in sedentary behaviour is associated with increase in low mood and associated with increase in social isolation and withdrawal from outside activities. So they are all very related, and if we can target physically, one of the big areas that's for mental health physiotherapy is loneliness. Do you work with loneliness? So loneliness is becoming one of the epidemics of the world. And the physical targets for physiotherapists, which we've written about in Australia, we created 5 packs for that, are things like sedentary behaviour. Again, the things we've talked about, step length, step speed is important, and strength. So if you work on those factors, you will decrease the incidence of loneliness. Very, very important. And I think
Working on a step length. Working on a step length.
More striking, longer striking, fast.
yeah, you go walk across there. Can I walk with this on? So let me show you. And we will practice a couple of things before we finish. To keep you awake, I think you're going to sleep.
Stand up a little bit.
All right. So let's just go up and down. Good, you all look silly. Okay, all good. Hand on belly. You can sit down. You can sit down. Who teaches belly for you? If I leave you with a couple of things to remember. One is always ask PHQ2, GAD2, right? Always. Easy. Evidence-based, statistically significant, helpful for tracking mood and anxiety with your clients, keeping an eye on them, helpful for referring on if you feel like you're not handling that or the patient is deteriorating psychotherapeutically. Does that make sense? Also, a way, and this is really, really important, also a way we have to start gathering data on how physio impacts psychotherapeutically. We have to start doing that. Psychologists do that. And then we get told it's not something physios do. But it is something physios do. When you come to see me in the clinic, you don't leave your psychological self sitting in the waiting room. You bring all of you into the waiting room. And now I'm distracted from my thought, which I often am. I'm going to show you the walking. So evidence shows us that I walk small steps, slowly, I'm more likely to be depressed. Okay? It's sort of logical, but we need to have evidence, and evidence shows us. This is interesting. So, how do you feel?
You're looking happy.
Happy? Jaunty? I know I can make it up those steps. I can climb that mountain. I can do have to tell them you're working on their mood. You just work on their step length. You get them to swing their arms. The other thing about depression in older clients is reduce As you breathe out, the belly goes in. The hand should stay still. All right? Let's do 6 breaths. You ready? Breath in. Breath out. Breath in. Breath out. Breath in. Breath out. Breath in. Breath out. Who's counting? 2 more. Breath in. Breath out. 1 more. Breath in. Breath out. Who feels relaxed? Easy to do. Diaphragmatic breathing shifts the body into parasympathetic stimulation, as you know. Switches on the vagal nerve. Vagal nerve helps with sleep stimulation, relaxation. Vagal nerve stimulation has been used in conjunction with post-stroke rehabilitation to take people out of anxiety and stress so that they can focus on rehab better. You can teach your patients to do their own vagal nerve stimulation with belly breathing or with meditation. Simple things that we can do with our clients to promote mental well-being. Easy? So things to take away. Don't be afraid to talk to your clients. Don't be afraid to ask PHQ2, GAD2, look it up, easily available, incorporate it into your assessment. Don't be afraid to ask about sleep, eating, alcohol, substance use. Don't be afraid to say to clients, do you experience any depression or anxiety? And have that conversation. And clients will often tell you more about themselves in that space. Don't be afraid if clients talk to you about things from the past. Don't think, we're going on about that thing again. Or, that's not what I'm here for. Listen. Listen to whatever that person says. I had a lady once with a sore neck, and when she came in, she was telling me her son was in intensive care. So she was spending every day sitting by his bed, waiting and watching. And she was very stressed this day because it was the day in Brisbane that the hospitals were allowed to stop wearing masks for COVID. And she was sitting by the hospital bed of her son, and the intensive care nurses came in and just ripped off their masks. And that sent her into stress and anxiety. And she came for physio. And while we were doing some neck treatment, she broke down sobbing. And she said, I don't know why, but I just had memories of my father. These things are normal situations. And the more you work with these presentations, the more you will attract that person to your door. And it's important that you allow whatever walks into the room to speak. That person may have been waiting, like my man with the father relationship problem who was in his 50s. He'd been abused by his father when he was 14. His father was in South America, but he was still experiencing the trauma of that relationship. There are people who need to talk. Is there anything else anyone would like to ask?
Being a therapist, is it very hard to put one's feet in other shoes and thinking like that? It is very hard for me as an emotional person. Whenever a patient comes to me with a different kind of stories, and then it's very hard for me to put my feet in their shoe and think like that. And then finding a very good solution for their problems. Questionnaires do help, but I do distract. I do distract the patients.
You get upset?
Yeah, I do.
Yeah.
Various patients, various history, various kind of trauma they are telling to me, I do get upset. Being a therapist, how you motivate yourself first? Because there, I suffer imagination very much.
Yeah. A drink of water. The thing I would say, and is my soapbox is self-care. And self-care, at World Physiotherapy Congress in June, we are doing a seminar on self-care. And that will be available online if people want to see part of that. I do not know what you do here exactly. I know in Australia, physiotherapists don't have supervision, psychological supervision. We don't do that regularly. We need to do that regularly. If we are going to work in mental health, we need, one, to look very much after our own self-care. Now, I'm going to say provocatively that if you work in mental health physiotherapy, you need to have counselling yourself. Very important. You need to look after your own emotional trauma. You need to be clear. You need to be able to say, I can't work with this person because they're emotionally triggering me, and therefore I cannot be the best therapist for them. And you also need to be able to check in with a supervisor once a month, frequently, to debrief. So we need to integrate that model of care into our physiotherapy practice, particularly as a mental health physiotherapist. We're not taught to think that way. I don't know about you, but in Australia that's a bit alien. But very, very, very important. If you work in pelvic health, you will hear lots of stories, lots of traumatic stories. So very, very, very important. I understand. I think you're doing a wonderful job with your clients because you care.
Yeah, in pelvic health, we have to deal with the patients who get assaulted, raped, early sexual abuse, and giving therapy and giving motivational sessions. We get disturbed a lot. The whole day when I get through these kind of patients, the whole day I cannot get attention to do my own work. I'm always distracted. I always think like 5 feet in their shoe and how they are. It's there is saying that there is always a different key of a different lock. I cannot imagine to find the key of their locks, what they are locking.
So do you think you have to?
Yeah, I do. I try to help them because I think
Because it's very important with empathy and emotional intelligence to differentiate self, excuse me, self and other. And that's what we have to learn to do. In order to be compassionate, we have to be separate. And that's part of the practice
yeah, I take time.
for you. And if you're struggling with that, it may be that you're experiencing some vicarious trauma. as well. You know vicarious trauma? Vicarious trauma when somebody expresses trauma to you and you have the response. So you're physiologically responding to their trauma, and that is not always helpful.
And so is it good to be emotionally attached with the patient? Because sometimes I too felt that after hearing a lot of things from the patients, at the end of the day, I felt emotionally drained. And when I went home, I got irritated with everything, like why this is happening, why there is so is it good, or like how can we be emotionally stabilize ourselves at that time?
Well, you need to develop some practice for yourself. So we've just done some breathing. We can do some grounding. Does everybody know grounding? Okay. Grounding is another way of bringing yourself into the moment, out of your body. I want you to have a look around the room. Thank you. I want you to have a look around the room and tell me something you see. What do you see?
क्या देख रहा है चारों तरफ क्या देख रहा है?
Lights, just students,
Stand up.
lights and posters, students, chairs, roof, lid.
Right. Sitting down. Thank you. And now something you can hear. What can you hear?
So lots of AC. I can now with your voice, I can find a lots of AC.
And what can you feel? So when you finish with a client and you're a little bit upset, you can sit down, you can do some breathing, and you can look through things. Something I can see, something I can hear, something I can feel. It's a mindfulness. It brings us back into our body, into our own experience, to create some separation. And in that space, we can be more compassionate with our action. Rather than, if we are triggered into our own psychological response in trauma, we will then be pushed into doing what we need to do to heal, rather than what this other person needs. So this is why it's important to have our own counselling, but also to be able to bring ourselves back to our own body.
How we can this cognitive behavior to patients? Is it works in application?
Okay, cognitive behaviour therapy. So similar thing as I said before. If you look at a trigger, this man with the sore shoulder, I'll use him as an example. So the trigger for him that was triggering the memory of his father was he had a friend that he was having conflict with. And he had conflict with his friend and they had argued. And so he was feeling abandoned. So that had triggered his memory of his father. And that had brought up the tension in his body. The reason being because his father used to physically attack him and he used to put his arms up like this. So he had a held pattern of tension in his body which was stuck. In trauma therapy, we talk about stuck points. So he had a physiological stuck point. His body had done that, and somewhere in his body, that position hadn't been resolved. So coming to physiotherapy, so with him, there were a lot of thoughts about his father, there was a lot of emotion, but the pattern was the tension. So the tension was the easiest point to work with him by just getting him to do safely. You can get someone to practice pushing away. You know, I'm pushing away my father, and that can resolve the process. But you have to look at what, if someone comes in, it might be very agitated emotionally, then you do the breathing. You do anxiety work, relaxation work. So contract, relax, do you know that one? Yeah. Yoga nidra, those type of processes. You have to shift one little link and then the whole cycle will shift. Yes.
So, I have one question, like, does working on a mental health really impacts the patient's pain that he's suffering? Because, for example, a patient comes and he says that I am suffering from extreme pain, but actually that isn't the pain he's suffering from. It's actually his unstable mental thoughts that is making him think that the pain he's having is to extreme level. But upon examining, we find that there is not such any major cause or any major injury that can cause the patient, what patient is complaining to us. So, how does the mental health affect what the way patient thinks about his pain?
First thing is that whatever the person feels is real, as you know. You want me to answer that first, or?
Good afternoon. My name is Tanay. I'm a student of Deputy Finally. So recently, I am on my clinical postings. One day, a patient comes with a severe pain in their shoulder. But after all the investigation or assessment process has been done, there are no any indication in their shoulder, which can indicate that patient have any injury or problem. It means it's suffering from a psychological pain. So how we can deal with this type of things?
You have limited movement?
Yes, ma'am. All things have been done, but well, yes.
Limited movement,
No, ma'am.
but some pain.
Yes, ma'am. Yes, when I was my seniors, they told me that these kind of patients suffering from a psychological some.
I think we have to be careful about inferring psychological, and we need to work with what's being presented. So if someone is presenting with physical pain, then that's the entry point into that cycle, into that maintenance cycle. So you accept that, and you aim to decrease the tension in the muscles and decrease the physiological tension first. Does that make sense? In the process of doing that, you may, like my lady with the neck, they may have a memory that they may share with you, or they may not share with you. But there will be release. There will be release something in that process. A lot of evidence now is around held memories within the cells of the body. So even by doing that manual therapy, you can release some of that held memory. I often say to people, it's like sweeping a room. When you sweep a room, you clean it, but you don't need to inspect every bit of dust. Sometimes you sweep a room, there's a big shiny thing, and you have to have a good look at it. But a lot of times you just sweep the room. So you treat that person respectfully, as I'm sure you did, and you validate their pain. That must be very uncomfortable for you. talk to me about when that pain comes on. You look at some of the triggers, this is the CBT. So you look at the associations with that pain. When does that come on? When does it not come on? I had a lady, does that make sense? Did I answer your question, Sam? Was that similar?
Yeah, I can see.
Yeah. I think the most important thing is if people with trauma want to be believed. You cannot have someone come in and say, I don't believe you have pain, or you never want to say, I can't find a reason for pain. There is pain there. Whether we call it, we know that physical pain is processed in the same part of the brain as emotional pain. So there's crossovers. So you work with what's being presented, you work with the language of the person and allow that to shift. And then see what happens. If it's a somatic presentation, they will come back very different the next day. And this is again, I think when you're first starting out as a physio, I know I did, you then thought, oh, they were bunging that on. You know, they've come back, they're better. But now I understand that you're shifting held postures and patterns of trauma in the body. And they can shift very quickly. And they might resurface somewhere else. Sometimes it's like pushing here and it pops up there. And then you trip that and it pops up there. And you might chase that a little bit. And it might take a while for the person to start, they will start sharing with you. They will tell you stories when they're ready to tell you stories. Yeah, is that helpful? Thank you. I had a lady, I'm not sure what time it is. We probably should. What time is it?
It's 1:30.
Do you want me to finish it?
Do you have any questions?
Did anyone has any question or difficult queries?
सर मैं कोई कुछ पूछना है?
At last, I would like to ask a question for all of us. What are the training courses available if someone wants to enter into the mental health? Any courses worldwide or any specific? What you can join, you can enter into that?
I think it's beginning. This is the beginning of it all. I know in Belgium, you can be trained as a physiotherapist and come out and do a master's in mental health, and you immediately become a mental health physiotherapist. In Australia, we come out as a normal physiotherapist, and most of us have our training separately as counsellors and psychotherapists, and then bringing it back together. And in the future, in the APA, Australian Physiotherapy Association that I'm involved in, we're developing that career path so that people will stay within the profession and become counsellors as well as physios. I think it will be a dual degree. So I would suggest anything to do with counselling would be, or health coaching would be very, very useful in physiotherapy and mental health. Does that make sense? Yeah.
Then I have a question. Earlier you mentioned that patients who have anxiety problems, we do high intensity exercises for them. So how it is related to this? Because anxiety part is already increased.
High intensity training.
Yeah.
High intensity training. How this is going to
That reminds me, I was going to say something to you too, as well. So, the stress response. We know the stress response. What happens when you feel threatened or unsafe? We go into, yes, fight or flight, or freeze. And so, when that's activated over and over, we don't completely switch off. So we have, and ideally, that stress response is meant to be triggered on and trigger off. Make sense? Yeah. High intensity can, sorry, I will get back to you. I didn't mean you to stand up. High intensity can help it trigger off. So I'm stressed all day, tense, 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 tense. And then I do some running on spot for 30 seconds, intense 3 lots of 30 seconds. It disperses that held tension, creates fatigue in those systems, and so you switch out of it, back into non-stress. Does that make sense? The other thing that high intensity does, you probably, are you the exercise lady?
Yeah, I'm supposed to.
Yeah, you would know better than me what I'm going to say, so correct me, please. But in the cells, in the middle of the cell, the mitochondria, when you do high intensity, you train that mitochondria to be better at releasing oxygen and being more efficient at using oxygen. And so you cope, your resilience is better, your physical resiliency is better, and that's correlated with decreased anxiety. There's another thing about physical resiliency. Have you heard of physical resiliency? 3 measures. One is how well you cope with less sleep. One is how well you cope when you get an infection or a cold. And one is how well you cope with cold water immersion. So those 3 things correlate with longevity and decrease in anxiety. So if you want to get better, another way of decreasing anxiety is cold water immersion. Have you heard of that? Yeah. What I wanted to say, I guess, relating to your question, have you heard of you would have heard, I don't want to sound patronizing, but the window of tolerance. Window of tolerance? Yeah. And that's what happens with people who have reduced window of tolerance. So if we are very, able to modulate well in terms of stress, that we encounter a stressful situation and we respond, and then we're able to switch off. We have a fairly wide window that we can hang around in and be relaxed. When people aren't switching off, that window of tolerance gets smaller and smaller. And so it's a bit like if you've had a really bad night's sleep and somebody says something to you, you might snap. Or when they touch you and you go, oh, hurt. So our capacity to cope is influenced by that window of tolerance. And so you'll find people who are experiencing higher intensities of discomfort and pain than we think they should be, is an indication that there's reduced window of tolerance and that there's trauma held in the body.
I have a very serious general question. Right now I am in final year. After that I am pursuing masters. How I can do this specialization is good for me.
What's the question?
This kind of career counseling. Lastly, which career, which specialization you should get into after completing the graduation? Like you have multiple options, sports, university. So what?
I think pain, exercise, and hopefully we will develop a Masters of Mental Health Physiotherapy, and we will have modules. So we will have a module of pain management. We will have a module of exercise, these lovely professors here. Chronic condition management is very important in mental health, so we will have a module of chronic condition management. We will have a model of stress management, the effect of stress on the body. We will have a module of trauma-informed care, and now trauma-focused physiotherapy is now another specialty. So, and then we would also need a module of life stage, so pediatric, children, adolescent, adult. So these are the things that would be important in terms of modules, and also obviously psychotherapeutic techniques, so CBT, ACT, acceptance critical therapy, compassion focused therapy is another one, and life review therapy. So life review therapy is working with older adults and letting them tell you about their life. And that is very, very good for mood support in older people. So when you go to see an older person, you're wanting to motivate them, tell me what you did as a young person. And oh, that sounds like you were wonderfully skilled at making art. Tell me about your art. And then as you're doing that, you do your exercise. Life reading therapy. So it promotes mood. It's a form of mindfulness and a distraction from poor mood and anxiety. So these are the sort of things that will evolve in the future. I think it will take a little bit of time.
You take a time for it. You go for internship first, then only keep going.
Yeah, I mean, the career pathway is going to take time. Yeah. In Australia, we're very frustrated. They're very impatient. I'm very passionate about it because I want to keep physios in the field, because a lot of physios are leaving. A lot of physios become passionate about mental health and then find they have to leave to work the way they want to work. And I think that's a real shame. Because as I say, working physiologically, when I work in my clinic, I work here as a physio, I can do counselling and I can touch people. When I work here as a counsellor, I can't touch people. It is really important that we use manual touch and therapy to create safe touch relationships. Very important. Do you know there's some people that don't get touched all the time? Nobody to touch them. Thank you very much.
So, hello? Hello? So, as Ellen Lake ma'am told us that everybody wants to be listened. So be a good listener because everyone has a story to tell. Now I would like to invite Himanshu sir and all the faculties to present the mementos to Ellen Lake ma'am.